Thank you, Mr. Chairman.
Yes, sir.
I want to thank your indulgence for us today. Everyone gets their say. That speaks highly of your, the way you run your committee hearings.
That's my birthday. What would you expect?
Absolutely. You're present to us, and
Yes, sir.
certainly we have a unique opportunity. We have, what I think Dr. Burgess, maybe it was Mr. Woodall said, that 6 people in the whole House that maybe have more knowledge about healthcare than anybody else. So this is truly an opportunity for us. You know, we've heard from certainly the in-depth knowledge of Dr. Burgess on this subject, the passion that you just heard from Mr. Byrne and Mr. Woodall, Mr. Collins. In fact, we even heard in one short dissertation from my good friend from Florida, from the Constitution, from the Bible, and from the lyrics of popular rock and roll. I just think this is a wonderful day, and made a great point. But this is an important topic, and I so much appreciated the discussion and what I think everybody and anybody that's listening has learned a lot today, and why it's urgent. And I appreciate people asking us to slow down, but you've heard from several folks saying how urgent this is because of the people we represent. And I was prepared to read a whole bunch of stories from my constituents as well, but you get the idea. People are hurting. This is costing them a lot, and so we have an urgency to move. So I appreciate all the information that you guys have given us today. I just wanted to use, and at this point in the day, we've heard a lot of things that I would have asked, that questions have been asked and answered, and so I wanted to focus on just a couple things. I come from the state of Washington, and my governor is served our state in this body. You all know Mr. Jay Inslee. And he has weighed in on the American Health Care Act on several occasions. And I just wanted to ask for my benefit, as well as for the benefit of the people I represent, because frankly, some of the things that have been coming from Olympia are concerning people throughout the state of Washington. And I would guess throughout the country, the similar questions are coming up. So I just wanted, if I could, and I direct the question to you, Mr. Walden.
Certainly.
Not just because you're from the Great Pacific Northwest and the state of Oregon, but because being the chairman of the committee, I think that you could help me to, in my estimation, get the right information so that people have the right information out there so they can make a decision. So as you know, Washington, like I think there's at least 31 states, we're an expansion state. And there's been several communications that have gone out by Mr. Inslee, as well as Mr. Kreidler, our insurance commissioner, but certainly Mr. Inslee has said that in our state, if this bill passes, that upwards of 600,000 Washingtonians will lose their health care coverage. And, you know, that is a concerning statement coming from the governor of a state that has been elected twice, has a lot of confidence from a lot of people, and I just want to ask you that point blank, is there any provision, you know, before we take this vote, in this bill that would cause 600,000 of my fellow Washingtonians to lose their current Medicaid coverage?
I can say with confidence that anyone enrolled in the Medicaid program today under the ACA expansion is held harmless, period, for those enrolled in the program before the end of 2019. So they can continue to enroll new people in the program up through 2019 at the enhanced match rate of about 90% at that point. Mm-hmm. Our plan would continue the enhanced match for as long as those individuals are in Medicaid. It's unfortunate that this other information is out there because it's not true. We made sure we're not pulling the rug out from those who are on it today. And in the future, they could add people on, but it's at their regular match rate.
So nothing will preclude people from staying on the Medicaid
Correct.
expanded program.
We made sure that, again, we're trying to land an airplane here, not a helicopter. So we have a glide path, but those that are on it can stay on it. For our states, including the Oregon, 90% match rate remains. So that means the state just has to come up with 10%. Now we can argue about able-bodied adults, you only have to come up with 10%. But if you're age blind, disabled, or child, state has to come up with, in my case, 37%.
Right.
why the federal government pays 90 for adults that are, you know, able-bodied adults and only 63% for age-blind and disabled is a whole nother topic that raises questions. But the answer to your question is nobody gets kicked off.
Well, I appreciate that.
The gentleman yield?
Let me finish my train
No,
of
but
thought.
you know,
here.
not for
Appreciate
anything, Mr. Chairman, but we haven't had, we haven't allowed a Democrat to speak for
Excuse me
some
just a moment.
time.
Well, let me just tell you how we work up here. The gentleman this is how we operate. And we do operate this way. Whoever has the question controls the time.
So I wanted to just, as a matter of fact, just yesterday, I had 2 appointments in my office. One from a group of individuals whose business is to take care of the elderly in our communities. The other was a group of disabled adults. Both groups, you know, different kinds of concerns, but one uniting message was they were concerned of the ability for the Medicaid program to continue delivering to them the kinds of things that they need because of, like you said, the able-bodied adults that are being paid for at a higher rate than they're receiving. So I appreciate you bringing that up. The governor and the commissioner continued in their communications by saying this, and I wanted to, this is something that also is very concerning to my constituents. If Medicaid expansion were to end today, at least 20,000 people would have their cancer care disrupted, and 30,000 would lose critical treatment for substance use disorder. And so again, can I ask you, is there any Medicaid provision in the AHCA that would result in 20,000 people having their cancer care disrupted or the 30,000 lose their critical treatment?
There's nothing in here that cuts that off today. I mean, you could come up with a lot of scenarios that aren't true, and that's one of them.
I appreciate that. So I appreciate you clearing that up. I know, you know, we've been getting a lot of calls in the office through my town halls, my teletown halls, my emails, letters from constituents. Even today, the phone lines are getting pretty warm. And those are the kinds of questions that people, I think, are asking, not only in my office, but others.
And if I could add to that, again, Washington State would get money from the federal government, even though it's an expansion state, just like Oregon will, through the Patient Stability Fund, Patient State Stability Fund. There's money there. In the legislation we passed last year, 21st Century Cures, there's I think it's $1 billion in there over a couple of years to deal with the opioid situation, or maybe it's $500 million to deal with the opioid situation. There are lots of other funds, and there's always the appropriations process here to provide assistance in these areas. And there's so much more work we want to do and will do through the committee to bring about more affordable options for health insurance. We had the bill on association health plans. We've got other things moving forward from our various committees, and there's all the work Dr. Price can do to improve the markets and improve access to more affordable care and services and give more authority back to the states so they can manage. And under the per capita proposal that you know, Democrats offered a number of years ago that we're embracing now, states would have some level of flexibility. And for the senior population, we actually provide additional funding because we know that's both a growing and more costly population, and for the disabled. So we have medical CPI +1. So they get what they're spending now with a ramp up, and then we peg it to CPI ME +1 to try, and we've listened to people. They said, you know, it's a really important population to take care of, seniors in nursing homes, and we said, you're right. And so that's why we made some adjustments here to try to get it right. We're taking our time to get it right. And so I appreciate the gentleman's comments.
Well, thank you very much, Mr. Chairman. I appreciate that as well.
Chairman, can I make a
Excuse me
query?
just a moment, please. This gentleman has.
Yeah, no, I've just noticed the previous speaker and now with Mr. Newhouse, you know, we have a number of witnesses here on the Democratic side who wanted to be recognized, and they've been routinely ignored. And, you know, there's $880 billion being cut out of Medicaid. This is a significant issue, and I think there's, you know, I think we engaged Republicans on our side. I just think it's out of courtesy that when a witness raises his or her hand, that they ought to be acknowledged and not just ignored.
I appreciate that, but what we're trying to do is let that person who has the time control the time. And I do respect you for offering that advice. Thank you. Gentleman's time.
I appreciate the concern. I do have a list of questions that I'd like to ask the chairman, and if there's time afterwards, I'm trying to respect, we've been here all day, and I want to respect
We're
people's
prepared to be
times,
here all night,
and
so take your time.
absolutely, absolutely. But just if I could continue my line of questioning, Mr. Chairman. Also, something else that I think needs to have some clarification. When the ACA went into effect, in the light of these accusations that people are going to be kicked off of and losing their health care coverage, but when the ACA went into effect, the insurance commissioner of my state made a decision that would not allow the grandfathering in of plans in the state of Washington for a number of people because they did not include the 10 essential benefits. At least that's my understanding. And that number was something in the neighborhood of, I think, of 290,000 people lost their insurance coverage that they purchased, they made the decision to buy, all of a sudden did not qualify. Can you give the rest of us some sense of what the impact of decisions like that was around the country, or are we an anomaly in that?
Well, no, I mean, it's hard to, every state's a little different.
Yep.
Every state's a little different. This did have national implications. Like you, I heard from people in my state that had a plan they liked. They were promised they could keep it. They didn't get to keep it. They got shoved into plans that maybe didn't have the providers they were used to seeing available to them anymore. I heard that from constituents and Enterprise and elsewhere, and it was a real problem. So I share the frustration that was expressed to you. Due to the disruption and chaos that was caused in the market, with folks losing their employer coverage and moving into Medicaid expansion in some cases, some people lost their individual plans and the like, and they were going without care, or people losing the individual plan they liked and then had to re-enroll in another. It's kind of a tough number to drill down. There was a lot of movement in the market and a lot of upset people. The most commonly cited number in news reports is roughly 5 to 6 million individuals, 5 to 6 million. So that's a wide range, I admit, but it's hard to get your hands around this. Had their plans canceled in the individual market. So 5 to 6 million people nationwide is the most normally reported set of numbers.
So it wasn't an unusual phenomenon throughout the state. Okay, one of my, the largest city in my district is just under 100,000 people. We are a rural district in central Washington. We truly are. And so my rural communities, my rural hospitals, and my providers, all of those things are really important. So I want to make sure that what we're doing, that we're just like the Hippocratic Oath, right? Do no harm. Our friend and colleague, Dr. Rowe from Tennessee, who is, I believe he's an OBGYN, correct? So he has the joke is that he has delivered most of his constituents. So that's one way to get reelected, I guess, right? But it's worked for him. But he has said that about 60% of the uncollectible debt in his local hospital system, and that apparently adds up to about $1 billion, is coming from people that have insurance, and that's up from a 40% prior to the ACA being enacted. So I guess my question then is, if the ACA has driven up these deductibles and out-of-pocket costs so high that an individual that actually may have coverage, they just simply can't afford to pay the bill for their care. So could you maybe expand on the fact that how we continue to see coverage that doesn't necessarily equal care? And in our bill, this AHCA, what kinds of steps are being taken to ensure that all Americans can have access to health care coverage?
I appreciate my colleagues' questions. One of Obamacare's costliest provisions is the federally mandated benefit regulations. These are expensive government mandates that are tied to a formula called actuarial value. And that requires plans to cover these benefits under a very strict cost structure. Our plan repeals actuarial value and gives states more control to regulate levels of coverage and benefit mandates. Combined with regulatory and administrative reforms enacted by Secretary Price, our plan will help give patients more health care choices over time, so you get more choices. Now, the Affordable Care Act used an illogical and random cost factor ratio to restrict the amount people pay in premiums. Specifically, Obamacare mandated that the cost of most generous plans for older patients can only be 3 times what younger patients pay for the least generous plan, when the real cost is actually at 4.8 to 1, according to health economists. So our plan accepts this reality. It loosens the ratio to 5 to 1, but it gives states the flexibility to set their own ratios. So if it turns out it needs to be lower for that pre-senior age group, they can do that. They can put it at a 1 to 3. They can keep it at 1 to 3.
Whatever you want.
They can put it 1.5 to 1. They've got that flexibility. But what we do know is the 1 to 3 ratio nationally has caused disruption in the market. This reform, we believe, will help bring some younger enrollees into the healthcare market that's deteriorating. Now, one of our most innovative ideas is grants to states to help provide care for low-income Americans who are uninsured and repair the damaged market caused by Obamacare. States can use these funds to help reduce premiums and deductibles for low-income Americans or stabilize their insurance markets. Again, Mr. Newhouse, every state's going to be different in terms of what's working, what's not, their age of their population, rural versus urban. So we grant more flexibility for plans to be designed and for support to come to the rescue. States can also use these resources to promote access to preventive services, again, like getting an annual checkup, as well as dental or vision care if that's needed, or substance abuse or additional mental health services if the state chooses that. The continuous coverage provision, we believe, is also important to bringing down costs because it ensures individuals cannot unfairly game the system and pay for coverage only when they have expensive medical bills. Doesn't happen a lot, but it happens enough that we're told it's a negative effect on the market. Even under the reconciliation bill, individuals can go without coverage for 63 days. By the way, that exists in other parts of insurance law, so it's nothing radical or new, and still maintain continuous coverage status. But most importantly, unlike the Affordable Care Act, our plan does not allow the IRS to fine Americans for choosing not to buy government-mandated health care insurance.
Mr. Newhouse, can you yield to me just for a follow-up question?
Sure, I'll just do
Yeah, just, Chairman Walton, I'm just trying to figure out, where in your bill does it protect people from not losing doctors or plans? Will insurance companies have to continue to offer the current plans? Where in the bill does it say that?
Say what, sir?
Sorry. Where in your bill does it protect people from not losing doctors or plans? And will insurance companies have to continue to offer current plans?
Well, they'd certainly be allowed to offer current plans. What happened under Obamacare is
But they
you
won't
all
have to.
decided, you all decided what that plan had to look like for every American, and that's
where
why
in
they
your
had to
bill-
cancel the plans.
Where in
Now,
your bill does it protect people from not losing their doctors or plans?
well, they can keep the plan they're on if the plan stays. We're not
The insurance
mandating
company
it.
doesn't have to continue to offer that same plan, right? I mean,
They could change their plans, that's correct.
so.
That's correct. But we also, by the way, you should note, Secretary Price has extended the grandmother plans, if you will, the traditional policy through calendar year FY 2018. So that's important.
Yeah,
We actually want to create new plans that work for people.
I don't want
And-
anyone to be misled that they're guaranteed.
No, that was what
No,
Obamacare
well,
guaranteed and
yeah,
failed
I
on
believe
miserably.
healthcare should be a right, not a privilege.
Well, yeah, but you all created a plan, a federal mandated plan that wasn't available, and so people were kicked off of their plans. 5 to 6 million people who had insurance, many of
This
whom
president-
liked what they had,
This president
were
is
kicked
guaranteed
off.
that everybody will get health insurance and that there'll be no changes to Medicare, and on both counts, he's wrong. Thank you, I appreciate it.
Yeah, thank you, Mr. Gunn. Reclaiming my time, one more thing that I wanted, as I recounted, I represent a rural district, as you do. Most all my hospitals are small hospitals, and I want to make sure that they stay open, that people don't have to travel for hours before they can reach a hospital facility. So one of the things that, I'll just be frank with you, that hospitals have told me is that they have been able to reduce the amount of care that they've had to write off because they're getting paid. What are some of the things that we are doing in this bill that will help rural hospitals be able to continue providing the kinds of care that we need in our rural communities?
Well, I think two things that are really important. If you're a non-expansion state and you're an expansion state,
Yep.
but if you're a non-expansion state, we turn off the disproportionate share cuts right away. Obamacare has these disproportionate share cuts whacking hospitals
We
all
stop
over
them right
America.
away.
For non-expansion states, they stop right away. If you're an expansion state, we turn them off in 2 years.
2 years.
2 years. But remember, you're also getting the additional expansion funds. And by the way, those do continue on. And it started in 2018, we provide the state, 2018, we provide the states with this beginning of the $100 billion. So they get $15 billion out to states in year one, $15 billion in year two, and then it ramps down a little bit thereafter over the next 10 years. The stability fund. And so that's a lot of money coming into state. And during this period, the same subsidies remain intact that are there today that help buy down premiums and buy down deductibles. The cost share reduction stays in place. These other plans stay in place so that we have a smooth transition to a market that actually will take care of it, that won't require as much federal subsidy. Because right now we're chasing a market that the costs are exploding. In Oregon, again, we were up 50% in the last 2 years in this market. Who thinks that's a victory? And it may go up double digits again. It may be high single digits. High single digits, I was a small business owner, paid those premiums. That was a lot of money increase every year. And you're getting less for it, and you're paying more for it. And so we have to fix the market, and that's where I get back to what I said earlier today. We also need to go after the cost drivers. This gives us a couple of years to go after these cost drivers that are out there. We know by GAO's own account, Government Accountability Office, they've told Congress repeatedly there's $36.3 billion last year in Medicaid alone in improper payments. Those people getting those improper payments, those providers, whoever it is, shouldn't be getting them. Think what we could do for your rural hospitals if we had that money to put to where it needs to be. And on the other side of this, we're also looking at new medical innovation. We're looking at how do we get telemedicine out to hospitals in rural areas. My district is, as you know, multiples the size of yours, and yours is pretty big. And so we're looking at how do we provide that access to care in these rural unserved areas and underserved areas. It's part of what Chairman Blackburn's going to be working on with broadband expansion out into these areas in the infrastructure bill that President Trump wants to do. We need to be able to get people access to care in that golden hour.
Critical. And plus the fact that we're going to allow people to stay on the expanded programs.
Yes.
As long as they qualify, correct?
On the Medicaid expansion,
That's
yes,
right.
they stay on at the 90% rate.
Right.
So the states are only being asked to put up 10%
Right.
for able-bodied adults.
All right.
Well,
Can I just ask, will the gentleman yield